Okay, again, welcome to today's webinar. My name is David Kanashko. I'm the Director of Education and Training here at Meditech, where we run actually North America's largest laser therapy clinic, as well, of course, we manufacture BioFlex low-level laser therapy, light therapy devices. Today's webinar is on carpal tunnel syndrome. And from what I gather, most people can hear me. I didn't have any reports that you can't. However, if you have any technical difficulties, just type it in and I'll see if I can address that as we go along. There will be a time for question and answers at the end of the webinar. So if you could just type in your question as we go along, I'll get to those and try and answer that as best I can. I get this question all the time after webinars. The webinar is recorded and is available to be listened to at any given time on our support page, which is password protected. So if you do want to listen to the webinar again, or you have to leave early or what have you, there's that option to do so. Okay, well, let's get started. As far as the agenda goes today, I'm going to do a brief anatomy overview of the carpal tunnel, a bit about the epidemiology, etiology, symptoms, and diagnostic testing for carpal tunnel syndrome. Again, this is a review for everyone, I'm sure, but it's always nice to have a good review from the days of when we were in class. I'm going to present a bit of research on carpal tunnel syndrome and low-level light laser therapy. And then specifically how we target and treat carpal tunnel syndrome with our equipment. And lastly, I'm going to have, again, a masterclass special discount for those of you who listen in. It is actually a much shorter time frame to respond this time. So again, I'll just remind you guys about that masterclass. And if you choose, you still want to come and you haven't made reservations yet, then you'll have a nice little discount for listening in to today's webinar. Okay, let's start off with the anatomy. This is a picture, obviously, it's showing with the skin removed. And those of you who have done cadaver work recognize this very clearly, showing you the actual carpal tunnel itself, the fascia of the hand as it turns into the actual transverse carpal ligament, and the superficial tissues that you see there. Of course, we're most interested in what lies deep to the carpal tunnel, specifically to the transverse ligament. And as you can see here, there's several tendons of the flexors, both of the thumb and the fingers, 9 in total, as well as the actual median nerve. So a cross-section of that same area shows you very clearly, remember this is on the palmar aspect of the carpal tunnel, showing you the rows of the carpal bones. The 9 tendons that are housed within the actual carpal tunnel itself. And superficial between the ligament and the tendons and the synovial sheath lies the median nerve. And this is, of course, where we find the entrapment occurring in cases of carpal tunnel syndrome. So keep that in mind as we're speaking and talking a bit more about the etiology and pathophysiology. So as you're probably aware, carpal tunnel syndrome is the most common focal peripheral neuropathy. And of course, is compression of the median nerve as it travels through the carpal tunnel. It occurs most commonly in adults, quite rare in adolescents or children, unless there is some kind of systemic disorder or trauma or what have you. And it's most common in females with a ratio of about 3 to 1. They suspect this has to do with the fact that females have a smaller carpal tunnel, just as far as anatomy goes. And therefore that lends itself to perhaps being more predisposed to developing carpal tunnel. It's most common in people who perform repetitive movements of the wrist, as we're quite aware of. And the prevalence in the general population is about 4 to 5%. So it's a relatively common condition, and I'm sure one that many people have come across in their clinical practice. The most common cause is really idiopathic. Most of the time, majority of the time, it tends to be bilateral. There's hypertrophy of the synovial membrane of the flexor tendons. This can be caused by degeneration of the connective tissue with vascular sclerosing, edema, and collagen fragmentation in those tissues. Interestingly enough, when I was researching this webinar, I came across a really interesting reference that talked about computer use. Essentially what they're saying, the research says that using a repetitive use of your hands in a computer of about 15 hours or less per week doesn't actually increase the prevalence in getting carpal tunnel. It's actually only when you start to use your wrists and hands for greater than 20 hours per week that seems to be more of an increased prevalence. So this is actually good information to talk to your patient about with respect to moving forward and helping with carpal tunnel syndrome. Let's talk briefly about the etiology, of which there are many. There's also aberrant anatomy. So, for example, congenitally small carpal tunnel, ganglion cyst formation, lipoma. Anything that takes up volume or space in the carpal tunnel can lead to the development of compression of the median nerve. Things like trauma is a fairly common etiology, like fractures or sprains at the wrist. Certain infections that can cause swelling and edema can also be problematic. And inflammatory conditions like rheumatoid arthritis, local tenosynovitis, and gout may also cause carpal tunnel syndrome. And again, anything that increases canal volume, so we know that it tends to be a bit more common during pregnancy as a woman's retaining fluid, but of course that's more of a temporary type of condition, being obese, hypertension, edema, secondary to repetitive use. These are all possible ways of increasing the canal volume. Certain metabolic conditions it tends to be more frequent in, for example, diabetes and hypothyroidism as well. As far as symptoms go, initially they tend to be more nocturnal or in the evening during the sleep, often waking the patient up. This is usually pain and paresthesia in the distribution of the median nerve, as shown in the diagram on the right, which includes a palmar aspect of the thumb, index and middle fingers, and the radial half of the ring finger. In the early stages, symptoms can vary widely. They can even localize to the entire hand or the wrist, to other areas, or radiate around the forearm. Much rarely does it radiate past proximal to the elbow and into the shoulder, but that can happen. So sometimes a patient will talk about some signs and symptoms, or especially pain, proximal to the wrist, and that can occur in CTS, so just be aware of that as well. Of course, you should be also looking for double crush syndrome or other areas that may also be causing similar symptoms. So patients often awaken with these symptoms. They'll try to shake it out, kind of get rid of those symptoms during the evening. This is called the flick sign, and if this is occurring in patients, it tends to be 93% sensitive and 96% specific for the diagnosis of carpal tunnel syndrome. Since sensory fibers tend to be more susceptible to compression than motor fibers, generally speaking, it's the paresthesia that's predominant and pain as opposed to motor symptoms. However, as this progresses, you then start to get issues with the motor fibers that will lead to weakness and eventual atrophy in late stages and more severe cases of carpal tunnel syndrome. One interesting note I discovered, I wasn't even aware of this, is that in late stages, actually you can get disappearance of pain. That can be a late finding. That implies a permanent sensory loss, and obviously a very ominous sign as far as the pathophysiology goes. So as a review, you're going to see sensory disturbances specifically in the median nerve distribution. Check during your examination for any motor loss or atrophy or weakness of the thumb abduction. So those are important screening tests, as well as diagnostic tests I'm sure you're all familiar with, like Phelan's, where you hold the wrist and you can either do unilaterally, bilaterally, when you have the patient hold for at least a minute or so, and looking for the symptoms to be aggravated or reappear. Tinel sign, tapping over the median nerve, and again looking for a positive response with respect to increase in tingling or paresthesia in the median nerve distribution. There's a few other tests, including compression and distribution between specific points. That's the SW monofilament or vibration sensitivity. And you can see here that when you're doing diagnostic measures, there's sensitivity which correctly identifies patients with the actual condition. So in this case, a positive test for carpal tunnel, or a specificity which correctly identifies those without the disease. So if you're looking at these types of testing, you can see that Phelan's and Tinel's don't have a great sensitivity. However, TENALS is quite specific for patients that don't have the condition, whereas other tests like true compression or sensory testing has a bit better sensitivity, especially vibration sense. Okay, let's talk a bit about some of the research that I've come across with respect to LLOT and carpal tunnel syndrome. This paper was a randomized controlled trial put out in 2014. It was a double-blinded randomized trial, 79 patients with mild to moderate carpal tunnel syndrome. I must make a note of a lot of the research refers to mild to moderate cases. You will find that it is recommended to treat these cases with LLOT. However, if it's a severe case, then chances are they won't respond very well. And those are cases more that require surgical intervention or more serious types of interventions. This trial used 780 nanometers of infrared light, 30 milliwatts, and a continuous wave. They treated 4 points with a contact technique. Each point they held for 90 seconds, so quite a long time frame. They treated 5 times a week, once per day for 2 weeks. So 10 treatments in total. Then every other day for 3 weeks for a total of 20 treatments. Okay, so they were looking at visual analog scale, they were looking at the TENALS sign, and they also did neurometrics testing as well for a nerve conduction test. Neurometrics, we use this in our clinic as well too, as a superficial EMG, quite easy to do, gets a result very quickly, almost instantaneously. So if you have the ability to do this or test for it, it really does give objective measurements pre and post treatment to really get a gauge to see if the motor fibers and the sensory fibers are improving with time and treatment. So they observed that there was significant reduction in pain in this particular trial. There was a reduction in the percentage of patients with a positive TENALS sign, and they also found a shortening of the sensory and motor latency with respect to the nerve conduction examination. So overall, they found it quite useful to use LLOT with respect to carpal tunnel syndrome. Another paper published in 2016, so fairly recently, they looked at, it was a meta-analysis essentially, looking at 7 randomized clinical trials. A total of 270 wrists were treated in these trials with laser group of 261, 261 in the control group and 270 in the laser treated group. They concluded that there was improved hand grip, improved VAS scale, pain, as well as a SNAP testing, which with respect to functionality of the carpal tunnel after 3 months. A follow-up for mild to moderate carpal tunnel syndrome. Again, make note of mild to moderate cases. They did recommend more high-quality studies to be done, as most meta-analysis studies require that, or mention that. Okay, so let's talk a bit about how we approach treatment. We usually use the wrist protocol, which I will show you here. The standard wrist protocol, we treat with one placement kind of sandwiched around the carpal tunnel area, but I'm going to show you a couple options of how to treat. So the first standard one is taking the array, wrapping it around the carpal tunnel. The first step is a dual red, of course. It is a continuous wave mode. So this is stage 1 for 8 minutes, which is a fairly lengthy treatment time at 100% power. That's followed up by the infrared dual array. It will be modulated using a square waveform. You can see that the frequency and duty cycle are relatively low at 10 hertz cycles per second and 40% duty cycle for 10 minutes. Again, a fairly long duration of treatment. The last step being the infrared probe, the LDI 200. We also use the red probe as well. You can use that if you do have it. Set to continuous wave for 6 minutes in and around the area for 40% power. So that would be the typical standard protocol for treating carpal tunnel syndrome. So essentially what I've described there is to sort of sandwich the array around the palmar aspect of the carpal tunnel. You don't really need to treat the dorsal aspect because of the bones. You really won't get any light directly into the carpal tunnel. However, there's another option that we tend to favor when treating carpal tunnel, and that's doing two placements. So doing the sandwich approach is a first placement, and then doing a parallel approach to try and get a bit more of the actual hand and the thenar region, and a bit distal to the carpal tunnel as well, and the median nerve. So we're going to do the first placement and second placement instead of just this specific wrapping around the carpal tunnel. So if that's the case, what we tend to do is use similar parameters, but we're going to drop down the treatment time of the red to 6 minutes in the sort of over the carpal tunnel, then another 6 minutes in the parallel fashion, and then repeat that same placement for the dual infrared at 10 hertz, 40% duty cycle. So similar parameters, just two different placements to try and get a bit more of the actual tissue, both proximal and distal to the carpal tunnel. So I would, if I were to choose the protocols, I would customize the wrist protocol and set it up as two placements instead of one. And similarly, use the LDI 200 probe at 40% power and the red for the same amount of time, 100% power if you do happen to have it. Moving on to stage 2, we'll start to tweak it a little bit, start to pulse out the dual red at 100 hertz, 90% duty cycle, and then increase the infrared to 3080 and increase the power of the LDI 200 to 100%. And then sort of increase in that stage 2, we can increase the frequency of the dual infrared to 5080. Okay, so we're still kind of within that stage 2 boundaries. And then into stage 3, you can really start to increase the frequency and the duty cycle of the dual infrared, keeping the other parameters pretty much the same. Okay, so that's sort of a breakdown of how we might approach using those two placements over several multiple stages of treatment. Don't forget, the laser probe should make contact at 90 degrees to the surface to enhance penetration and, of course, minimize reflection. Try to push the probe into the skin to depress the tissue. This allows, again, for the light to go a little bit deeper, a bit more accurate into the actual area that you're treating. So that's a really important step to ensure that you're getting appropriate tissue penetration. As far as the probe itself goes, essentially what you want to do is treat along the path of the median nerve, and then you want to treat and cover the entire carpal tunnel, as well as the thenar eminence and the branches of the median nerve, all the way into the first and second finger areas. Okay, so each time you treat with the laser probe, you're going to hold it for 4, 5, 6, 7, even up to 8 seconds, especially over the carpal tunnel region. You can maybe hold it for a little bit less into the thumb and the fingers, but essentially you want to make sure you treat the entire carpal tunnel, both proximal and distal, into the thumb and the branches and the superficial branches of the median nerve, because they of course are also affected. Okay, so as I just mentioned, you want to hold the probe for about 5 to 8 seconds per point. Once all the points are treated, you can actually go back to the median nerve location in the carpal tunnel and treat again, just to get a bit of extra dosage in there. But I wouldn't go back to it more than twice or so. Again, no need to treat the dorsal aspect of the wrist because you're just going to be irradiating the bones, which won't get any of that light directly into the carpal tunnel. And again, if you have the LDR 100, it's also a valuable tool to help with pain and especially the paresthesia in superficial nerves for treating those areas. A few treatment tips. In severe cases, recall, as I've mentioned, they have very poor prognosis. So if a patient's coming in with muscle atrophy, showing really signs of advanced stages of carpal tunnel syndrome, it's probably not likely to do a lot for their condition because they're that far advanced. If a patient's not responding after increasing the parameters, look at treating the cervical spine in stage 1 with an emphasis on treating the nerve roots of the median nerve, which are C5 to T1 on the affected side, or bilaterally if they have bilateral carpal tunnel syndrome. We do find that patients respond well to stimulation of the origin of the median nerve at the level of the neck when patients just aren't doing as well as we'd like when treating just local over the carpal tunnel. So you certainly can add that on to your treatment regime when treating the carpal tunnel. You don't have to start off with treating the cervical spine. Usually for mild cases, it's fine to start at the level of the wrist. However, if you do want to add that on, there's certainly, it would also be helpful. Try and treat the patient consecutively for the first few days, then moving to 3 times a week. That is every second day until the patient has made significant improvement, at which point you can start to reduce to once or twice per week until they've achieved maximal medical recovery. So typically a treatment plan for mild cases might be 10 to 15, moderate cases 15 to 20, 25 plus treatments. So you do have to be upfront with your patient. It's going to take a bit of time. Remember that nerves heal extremely slowly and that you need to be aware of that. Also, you have to address potential underlying causes, whether there's ergonomic issues you have to address, the use of computers, that kind of thing, any underlying systemic diseases that need to be treated. All those different things need to be looked at if you're going to have good clinical results. Okay, so last few minutes, what I'll do is just do a little reminder for everyone. We do have a masterclass coming up on Saturday, May the 13th. It's the full day event, 9 a.m. to 4:30 p.m. Local here in Etobicoke, Toronto. It's registration's at 8:30 and it starts at 9 o'clock. Dr. Khan will be in attendance. He'll be speaking a bit about, I'll talk about what he's be talking about, along with Ben Ewan, Andrea Dixon, Slava, myself, and Nicole and Stuart Carter. I'm offering a very last one-time reduction in the pricing for attendance there, $100 off for 24 hours only. So that is at the end of this webinar, you have 24 hours to sign up. And that gets you $100 off, which essentially is the early bird pricing. However, that's only for 24 hours. So if you're still on the fence about coming, it will be a really great event. Really interesting to listen to some of our keynote speakers. Dr. Khan was talking about the history of his work here in Meditech, along with some really fascinating case studies that he's treated over his last couple of decades. Dr. Ewan, which probably has, again, one of the largest laser clinics in North America, he'll be doing some case studies on COPD, carpal tunnel, interestingly enough, fractures of the humerus and pelvis, scar healing, TMJ issues, several shoulder pathologies, and so forth. Dr. Ewan's always wonderful to listen to. Very great clinical insight into using laser therapy and manual therapy. So it's always a pleasure and a treat to listen to him. Of course, we'll have Slava. He'll be talking about customizing standard protocols for several cases, including migraines, chronic regional pain syndrome, and a really fascinating story about a boy that had a speech disorder. Nicole and Stuart, husband and wife, RMT and osteopathic team, they'll be talking specifically about the arthritides, everything from JRA to psoriatic and osteo and post-traumatic, and about using laser and massage therapy techniques. And they've had some wonderful results, so it's great to have them on board. As well as Andrea Dixon, another RMT. She'll be talking a bit about women's health issues. She's getting great results with that. So that will be really fascinating, along with goal setting and patient education and development of treatment plan. And I may also say a few words about the latest clinical research trials, as well as the evolution of laser therapy's entrance to medical mainstream through now what we seem to have a much greater number of evidence-based guidelines to dictate that it's a very good and useful tool for clinicians to use. All right, so I think we have a few questions here, and it's going to get to them right now. Okay, so let's see here. I have a question with respect to how many total joules in this treatment protocol by Damien. Damien, I didn't actually walk through the number of joules. If you're really interested in the exact specifics, I'll give you my email at the end of this, and I can certainly get that to you. The joules are different based on the equipment that we're using. So for example, when we're holding the laser probe for 5 or 6 seconds or 8 seconds, that's going to alter the number of joules at that point. And of course, using the array has a different amount of joules because it's spread out of a much larger area. But I can get that information to you as well. Another question here from Julius is jumping from stage 1 at 40% to stage 2 at 100%. Would you hold the probe for less amount? for less time per area. No, I would still hold for the same amount of time. Remember that you can fluctuate the time that you hold. If you're finding that the patient isn't doing as well at a few seconds, increase it by 1 or 2 seconds each time you treat. But what you don't want to do is hold it for too long because you may be overdosing, at which point the results won't be as good. Haroon has asked a question, will you show results from other trials? It may be useful to see actual results that Meditech and Bioflex gets. I think we have some information. I think Dr. Khan, I can't remember if he did one or not on carpal tunnel syndrome, Haroon. Let me see if I can find that. And if you're interested, send me an email. But I'm not sure if we have specific clinical trial here at Meditech on that condition. Can laser therapy help carpal bones stay in place? I have a client who has had carpal tunnel syndromes, which goes away with car adjustment, probably ligament laxity, so not real carpal tunnel. If the wrist bones are adjusted, the laser then applied, will that help? Or if not, over time, this will turn into full carpal tunnel syndrome. Okay, that's a good question. I think realistically here, if there's ligamentous issues, it will help to strengthen or actually increase collagen production in ligaments. So essentially will help them to heal. But if there's a mechanical instability, that is also an issue. So I guess really what I would say is that laser therapy is known to increase collagen production and help improve the integrity of ligaments. So in other words, it should help the laxity of the ligaments that you're referring to, Jill. But of course, that would take a fairly lengthy treatment plan for that to occur. But again, it would depend on the extent of the ligament pathology as well, too. You mentioned that with the probe to treat the same point 2 times. Is there a general rule for how many times at the same point should be treated? Really, the general rule I would say is that the area that's most involved, you can go back and treat at least another time or 2. And if it's just the periphery areas, smaller areas not as involved, usually just treat over them once, generally speaking. Which trigger finger, will trigger finger respond to similar protocol? Use the hand, for trigger finger, use the hand protocol, Barbara, for that. And last one says, I love you. Oh no, it says, I love it. Thanks, Damien. Again, I really appreciate you guys spending the time with me. We're really getting great turnout for these webinars, typically around 300 people registering for them. With over 100 people listening in. So I really do appreciate you spending your time with me. And I will see you next month. What I should also mention as well, too, as we're speaking, is that we do have 2 certification dates you should be aware of in Vancouver on June 2nd, 3rd, as well as May 26th, 27th here in Toronto for our next certification dates. So I'll see everyone next month for our next webinar. Take care.